Good evening, everybody. I'm Dr. Sangshaptak Saha, and today, today and the subsequent few 2-3 classes will be dedicated to endocrinology. I shall be covering the breadth of endocrinology over the next few classes. Today's class will mostly be on the growth hormone and not a growth hormone, on the things like SIAD and the diabetes insipidus and a bit of vasopressin, and mostly it will be on thyroid hormones and its different the different topics from thyroid hormone from which the MCQs usually come in part 1 and part 2. Both the classes, today's and the next week's or the next class, all will be based upon the theoretical part, where I shall be just be discussing the parts from where the usually the questions come, and the last class will be based upon MCQs. We shall be discussing around 40-50 MCQs in the last class. So we shall not be discussing everything about endocrinology. That is not possible in a couple of classes. We shall be just be discussing about the things that usually comes up in the MCQs. So I think once a few more the candidates join, then we shall be ready to start, which I think from 7:10 we shall start the class. So in endocrinology, before we start, endocrinology, the majority of the MCQs, they usually appear from SIAD, diabetes insipidus, thyroid related. Among thyroid also, the usual topics are thyroid malignancy, Graves' disease, the different eye signs. Then then this thyroiditis. Of course, drug induced, anything drug induced is a hot topic for MRCP as always. From thyroid, amyloid-induced thyroiditis and its types and how you differentiate. One question from every candidate, at least 1 to 2 questions, and either in part 1 and part 2 will appear in the exam. I don't think anybody can pass both part 1 and part 2 without answering a question amyloid-induced thyroiditis. Anyway, apart from these two topics which we shall discuss today, the other 2-3 important topics are the calcium-related things. That is calcium phosphate metabolism and related and the hypoparathyroidism, and a few emergencies, hypercalcemia of malignancy, those type of things, and also adrenal gland. Definitely adrenal gland, which along with thyroid and adrenal, these are the two topics from which maximum questions come in from endocrinology. In adrenal, we shall discuss a lot of things: ACTH, cortisol, right from where they're secreted, right to the receptors on which they act, and then the adrenal crisis, additions, everything will be discussed. Please switch off please mute yourself. And yeah. So apart from these, we shall be discussing a few other short topics which I found MCQs have come in the last 5-6 years. Okay. And in the last class, we shall discuss around a few MCQs from every topic so that you get an idea. So I have basically taken up screenshots, not from any books, I mean, obviously from the books, but from the topics that I marked as important for my preparations. Now, I passed my MRCP part 1 in 2019 and part 2 in part 1 in 2016 and part 2 in 2019. So I have taken the part from those, and I have also gone through the last few years MCQs before I made this PPT, and I have tried to include the topics which have come up in the recent exams, in the recent diets, which more or less were the similar topics in the, like 4 or 5 years back also. Okay, so it's 7:09. I think we shall start. I think almost everybody who wanted to join has joined the class. It will be around 1 hour class. I don't think attention span is there for more than 1 hour. So first is that we shall start with the pituitary gland. Growth hormone we shall discuss as the last topic for the second class. So today vasopressin first. So vasopressin, the first question that they usually ask is which receptors are involved. So V1, A, B, and V2. So the question will be based on V1, V1V, and V2. So first we shall discuss V2. V2 is cyclic MP related, whereas V1s are V1s are G protein coupled phosphodiethyl inositol mediated, the secondary messengers. Both are previous year's questions. V2, it is mostly renal. However, extra renal is also there. Why do you need to know this? Because for the renal mechanism, we are using this drug desmopressin, and which is mostly for which is an analog for vasopressin, which is more potent and long acting, and it is given intranasally. It is used for treatment of hypernatremia for this nephrogenic diabetes insipidus. Whereas for V2, the desmopressin, the extrarenal part, the extrarenal part, this causes this increased release of von Willebrand factor 8. That is why it is used for the treatment of hemophilia A and von Willebrand disease. So one is the renal part, which is for this antidiuresis part. As we know, it acts as the level of aquaporin 2 channels. And you are not using vasopressin, you are using desmopressin because it is more potent, long acting, and the route is usually intranasally. However, paroral and IV routes are also there, but for examination purpose, intranasal is good enough. The dose is 10 mics intranasally. We also have got an external component, external, that is associated release of von Willebrand factor and factor 8, and it is used for treatment of hemophilia A and VWD disease. I mean VWD and hemophilia. Whenever you study, you always make note like I am making. I am making it so that you get a habit of doing this. Then it will very easy to revise in your just 10 days, 14 days before the exam. Anyway, what about V1 A and V1 B? Why are they important? V1A acts on the vascular smooth muscle level, and the drug is terlipressin. Terlipressin is used. Terlipressin is again just like desmopressin. Just like vasopressin. It is mostly used to reduce the esophageal varices bleeding, that is in upper GI bleed. Felipressin is for theoretical part. I don't think it will act in MCQ, but it will prolong the action of local anesthesia. That is similar to adrenaline action because it acts at the level of the vascular smooth muscles and causing vasoconstriction. It also causes platelet aggregation. These are the two MCQs which are important: vasoconstriction, platelet aggregation. What about V1B? V1B acts at the level of the anterior pituitary gland. It releases ACTH. It is also associated with prolactin. We shall see why this is important. There is an MCQ based upon this. So these are the vasopressin receptors. And as you see, the whole chart is an MCQ. 6-7 MCQs have already come from this chart, single chart alone. Next is, when is it released? The main stimulus is increased osmolality of plasma. Why does this happen? Because the action is it will reduce the extracellular volume. So the main stimulus is increased osmolality of plasma. And what is the action? The action is it increases the dilute urine. So the urine osmolality will obviously decrease because dilute urine, lots of urine. Urine output will increase. If the lot of dilute urine is there, the plasma osmolality will increase, and consequently the plasma sodium will rise. So this is the action. Because MCQ, especially in the part 2, MCQ will not be directly, this thing. They will give you a case scenario where this information will be given. Then you have to correlate the DST, which is diabetes insipidus, and there is lots of vasopressin being secreted. Okay. So the main stimulus is increased osmolality of plasma. Another is hypovolemia, blood loss, hypotension, hypoglycemia, and also drugs, carbamazepine and anti-neoplastic drugs. Carbamazepine has already appeared in MCQ. Antineoplastic drugs, there are lots of examples. And for all practical purpose, it is difficult to remember every drug interaction, right? So only remember the drug interactions which are coming very frequently in the exam. And for that, you have to make a note which drug interactions are coming and note it down and revise it 1 week before the exam. Because it will be very difficult to remember carbamazepine is the cause of this increased secretion of vasopressin. But yeah, it has already come, so I have included it. Factors decreasing the secretion. So far, only the Wolfram syndrome has come in the exam. That is also 2 to 3 times in the last 5-6 years. So not very frequent, but try to remember. The others have not yet appeared in the exam. This is a direct question. What is the most likely explanation for the patient's hyponatremia who has presented following a road traffic accident, rapid pulse, low BP, low sodium, physiologic ADH secretion? Okay. That is the physiologic ADH. So this is not vasopressin, remember. There is low sodium. So the physiologic ADH secretion is appearing. So it is not pathological. So just you have to wait and observe for a few days and then repeat the sodium. Maybe it has already improved. So next question is SIAD, syndrome of inappropriate diuretic hormone release. So that is increased ADH. The ones marked in red have already appeared in the exam. The most common cause is small cell lung cancer. The other common causes are other cancers. It can be following a neurologic condition, which can be a hemorrhage, it can be meningitis, it can be other CVA, that is cerebrovascular accident. Similarly, tuberculosis, HIV can also cause it. Drugs, very important. Almost all the drugs mentioned here already come. Thiazides, SSRIs, phenothiazines, tricyclic antidepressants, vincristin, vinblastine, omeprazole, and also cyclophosphamide. So 5 to 6 drugs have already appeared, drugs causing SIAD. So these you have to remember. The previous slide I told you that you may forget that carbamazepine is a cause for production of this ADH. But here you have to remember these drugs because they have already come in the exam and it will come. SIAD and drugs. And this SIAD is a cause of acute intermittent porphyria also. It can be associated. So they may give a SIAD-like condition and so they may give a SIAD-like clinical features plus seizures. Definitely in a young female. And one of the causes will be acute intermittent porphyria, one of the options. And that will be the answer. So these are, if you know, you can answer. If you don't know, you can. It's not possible to find out the cause there and then. So CR the associated with AIP, and the question that has previously come in MRCP part 2 was this. Okay. So what is the management? The basic CR management is restriction of water intake, except a few situations. Those exceptions will not come in the exam. So if there is stop the IV fluids or fluid restriction is the option, that will be the answer. Firstly. Secondly, you have to find out whether the patient is at a risk for developing seizures or coma. If so, or if the patient is already having seizures, then you have to immediately correct the sodium with 3% NaCl. This one. But only if it is severe and if it is symptomatic. So who presents with neurologic abnormalities, that is seizures or poor GCS, then the treatment is 3% saline. Otherwise, 3% saline will not be the answer. If it is a chronic case or if the patient is like GCS is full, no seizures, then you have to just go with the fluid restriction. What about other options? Other options rarely comes in the MRCP part 1. It can come in part 2. Second line is demeclocycline. Third line is ADH, that is vasopressin, like tolvaptan. But for tolvaptan, there is side effects, especially hepatotoxicity. So another MCQ, before starting tolvaptan, you have to look at the LFTs. LFT investigation, it needs to be done. or if the hepatotoxicity already there, then tolvaptan you cannot give. And obviously, if the patient is any of these drugs, then you have to stop the drug. You see, MRCP part 2 is especially, this is not come in part 1 because part 1 is more like are these which are the polyndrous cause CR, those type of questions. Part 2 is more of the clinical questions. So part 2 you have to use a common sense. If the patient is having the drugs, obviously you have to stop it. That will be the first line rather than the fluid restriction. If it is not there, then fluid restriction is the first line. Okay. Secondly, diabetes insipidus. Diabetes insipidus I have already discussed. That is, there will be this low urine osmolality and lots of urine, along with a high plasma osmolality and a increased sodium. Diabetes insipidus can be cranial diabetes insipidus, nephrogenic diabetes insipidus. And another thing is gestational diabetes insipidus. Cranial diabetes insipidus means there is deficiency of ADH. There is low ADH. And it is also the most common type. Again, a part 1 question, which is the more common type of diabetes insipidus, it is cranial type. Nephrogenic type is more rare, and gestational, obviously, because of the placental vasopressinase, that is this will decrease the vasopressin. It destroys the vasopressin. It is the vasopressinase which causes gestational DI. Causes is unlikely for MRCP exam, but few of the causes you have to remember: primary or secondary. Primary means the most common cause is idiopathic, or it can be a part of Wolfram syndrome, as I have already discussed. Wolfram syndrome already come in the exam. It is a mnemonic died mode. Please remember the mnemonic. It has come multiple times in MRCP part 1 and part 2. This one. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Secondary causes I have discussed anything related to the brain. If it is an infection or a trauma or a stroke or a surgery or a sarcoid, that is neurosarcoid, anything can cause secondary DI. Now, nephrogenic diabetes insipidus. It can be because of vasopressin 2 receptor mutation. It is an X-linked disease. My advice will be to make a list of X-linked disease, autosomal dominant, autosomal recessive, and keep on adding it as you go through the different domains, because those come up in randomly in part 1, part 2, and it is a knowledge-based answer. So if you know, you know. So make a list, go through it at least once a week from now on till your exam. Then you will remember it, and that will help you answer at least 2 to 3 questions. That's a lot for an MRCP part 2. Because most of you will give the exam after studying a lot. Most of you will pass anyway. But few of those unfortunately will not make it. They will not make it by 5 to 6 questions. So if you make this list, you will get maybe 2 to 3 questions, which in my view will be a bit difficult if you do not make up this list. And yeah, so try to focus on these which you can address, these deficiencies which almost everybody has. I mean, nobody can remember all the AD, AR, and X-linked diseases, right? It's not humanly possible. So if you make this list, you can add to your list of 2 to 3 questions. Okay. Now we have already discussed the CR and the drugs. Now it is DI and the drugs. Again, an exam hot topic. The drugs are tetracycline, tremethocycline, lithium, and these signaling inhibitors, which mainly causes nephrogenic DI. These are the 2 drugs which have already come up in the exam multiple times. Lithium induced diabetes insipidus and tetracycline. Again, a demo. Their demo is that in part 2, this question, I think if you have gone to the endocrinology part, MRC part 2 question, you have come up with this. A male or female patient has gone to the psychiatry OPD with altered sensorium and this type of things, and they will not mention the patient is lithium. They will mention that the patient has gone to psychiatry OPD or has a history of psychiatric illness, and now these are the lab values, and they are very cleverly they will give the sodium value and the urine osmolarity. Then you have to correlate with the nephrogenic diabetes insipidus, right? So that is the way they will expect you to clinically correlate. the things. Diagnosis we have discussed. There will be high plasma osmolality, low urine osmolality, and a high serum sodium. Now the water deprivation test with response to desmopressin, following which desmopressin, that is DDAVP2, needs to be given. If it is cranial diabetes insipidus, then the thing will be corrected, because they are the main problem, which is the desmopressin deficiency, ADH deficiency. In nephrogenic diabetes insipidus, the problem is the receptors. So there will be no significant response to desmopressin, not a partial response. You also have to do a CT scan or MRI of the head, because to rule out brain tumors, also for meningitis and trauma patient, you have to do this thing. So these are the two questions that comes. Cranial, it will be almost complete correction. Nephrogenic, it will be partial correction or no correction. Management wise, central diabetes insipidus, the management is desmopressin, which is a drug of choice. For nephrogenic diabetes insipidus, thiazide diuretics, amylorides, NSAIDs. Especially amyloride is a drug of choice for lithium-nephrogenic diabetes insipidus. So these things you have to just basically remember. There is no other way. Thiazides, amylorides. If it is nephrogenic, lithium-nephrogenic DI, then amyloride is a drug of choice. Now, this question is coming up in the recent diets. This is basically for the ICU patients, or patients who are quite sick, that is symptomatically sick, and you are using this 3% NaCl to increase the sodium. There, 5 millimole per liter in the first hour. The limit is 10 millimoles per liter for 24 hours. That is, in one day, the maximum that you can correct is 10 millimoles per liter. Nowadays, they have actually reduced. They are telling that in 12 hours, you can correct up to 12 millimoles per liter. 10 millimoles per liter maximum. This is if the patient is having like active seizures, poor GCS, where the only cause of GCS is this low or high sodium. High sodium. There only you can use this. Otherwise, it is one day 10 millimoles per liter. So this will come up that what is the target, or this much has happened. Now the patient has become more drowsy. What will you need to do? You need to immediately repeat a CT scan, brain, or better an MRI, and correct the hypernatremia. You are correcting hypernatremia, right? And if you are overcorrected, then suppose sodium has gone from 158 to 142 in a matter of 8 hours, and the patient has become more drowsy. Immediately you have to give 3% NaCl to bring back the sodium to about 150 plus level. That is whatever your initial target. So this is the pathophysiology. I am an intensivist, so I do this often. And yeah, so that is there. It is also coming up in the MRCP exams also nowadays. This we already discussed. This is a previous question. Which part of nephron? Obviously, it is a collecting tubules, because it is related with the vasopressin, and vasopressin acts on the collecting tubules. So that is the center of interest. If there is a hypovolemic patient, leave aside hypernatremia. If there is a hypovolemic patient with hypotension, tachycardia, poor skin turgor, you have to restore the volume with IV fluids. And on the top of that, if the patient has got a low sodium, then yes, you give 0.9% saline. But hypovolemic patient, you have to restore the volume. That much is sure, regardless of any other clinical scenario. Unless the patient is like life-threatening heart failure, you have to give the volume. Even in a CKD patient or a CLD patient who has for some reason gone into hypovolemia, you have to give the IV fluids. So CDI, NDI, we have already discussed. What we have not discussed is primary polydipsia. We shall be discussing it. So lab finding, obviously hyponatremia, because it is mostly dilutional. Plasma osmolality will be low, and the patient will pass a diluted urine. So everything will be low. Sodium low, plasma osmolality low, urine osmolality low. Desmopressin administration, there will be no need to administer desmopressin. Why? Because it's a clinical diagnosis. If you are doing the water deprivation test, and if the plasma osmolality is now normal and the urine osmolality rises and reaches normal value, that means the ADH release and effect both are intact. So you do not need to give desmopressin in primary polydipsia, right? I think everybody knows this. We do not give desmopressin in primary polydipsia. And if you are and it water deprivation test is showing urine osmolality no change, that is nephrogenic diabetes insipidus, and CDI it will be completely corrected. Water deprivation test in both. I'm so sorry, I told it wrong. Water deprivation test in diabetes insipidus, both there will be no change. And then you give desmopressin. Then if you give desmopressin, then for CDI, urine osmolality will rise, and urine osmolality remain low for nephrogenic diabetes insipidus, as we already discussed. So that is the usefulness of the water deprivation test and desmopressin administration, and both of these comes repeatedly in the exams. This same thing has been told. I think we all know by now what to do with the case of CR, the diabetes insipidus, or hypogenic polydipsia. Coming to hyponatremia in general, first is this classification: mild, moderate, severe, 130 to 135, 125 to 129, less than 125. If it is less than 125, you need to treat. If it is mild, you can observe also. If it is less than 48 hours, it is acute. Especially for part 1, these things will directly come in the exam. This is the sodium, what is it? This patient is complaining, this patient has this sodium, now it is like this, it is 24 hours, whether it is acute or chronic. You have to tell that it is acute, because the cutoff is 48 hours, not 24. What are the causes of pseudo-hyponatremia? You see, preparing for MRCP part 1 and part 2 is just going and solving MCQs. There is no like shortcut. You have to go through the theory part and then you have to go and solve the MCQs. So pseudohyponatremia can occur if the sodium, if the glucose, if the lipids, if the proteins are increased, everything increases. Hyperglycemia, hyperlipidemia, hyperproteinemia. But in pseudohyponatremia, obviously serum osmolality and these things will be normal. And if the patient is taking lots of lipid, lots of glucose, lots of proteins, then, or if the patient is having taking lots of alcohol, ethylene glycol, methylene glycol, those type of things, polyethylene glycol, then there will be a case of raised osmolar gap also. I think in your ABG class we shall discuss. You will be taught about raised osmolar gap causes and these things. But in most cases of hyponatremia, if you're measuring the osmolar gap, then you will be, pseudohyponatremia, if you're measuring the osmolar gap, you'll see that it is raised. So now how to approach a patient of hyponatremia? Step 1 is to measure the plasma osmolality to see whether it is low, high, or normal. If it is low, that is the usual response, and then we have to assess the volume status. This is step 2. Hyper. In hypervolemic or hypovolemic or euvolemic, we always have to measure the serum sodium. So that is the step 3. So step 1 is plasma osmolality, step 2 is the volume status, step 3 is urine sodium. And based upon different findings, we have to classify whether there is any, like if the urine sodium is more than 20, then there is a renal solute loss. So there is possibly a renal injury. If renal sodium less than 20, then it is extra renal salt loss. So it can be dehydration for other cause, lots of sweating, any GI loss, those types of things you have to rule out. If it is euvolemic, then the causes are CR, hypothyroidism, hypoadrenalism, and also diuretic use. And if it is hypervolemic cause, then mostly heart failure, CLD, cirrhosis, renal failure, nephrotic syndrome, you have to rule out. If it is isotonic hyponatremia, that is the step 1, plasma osmolality is normal, then obviously, as you discussed, it can be pseudo hyponatremia. If it is hypertonic, then maybe the patient is getting some hypertonic saline like mannitol or 3% NS, or not 3% NaCl, like mannitol or glycine. So this is how we approach a case. In part 2, they may give a part of the information and tell you what you will do next. Based upon this chart, you need to answer. Management we have already discussed, so that's what we have already discussed here. So not going into these things again. So this is a case of, so this is one thing that we shall discuss the growth hormone part in the next class, but this we have included here because this is basically a case of pan hypopituitarism. So there it will be like growth hormone deficiency, ACTH deficiency, TAC deficiency, FSH deficiency. So if you are getting more than one hormone deficiency, in usually they will give a clue like post trauma, post encephalitis, patient is altered sensory fever, those sort of things, or post neurosurgery. Then you have to take the call of pan hypopituitarism. So basically, the patient will have a short stature, tiredness, weight gain, acidity deficiency like features, say postural hypotension, hyponatremia, hypoglycemia, TAC deficiency like cold, clammy skin, lethargy, constipation, weight loss, and also in women, primary amenorrhea or secondary amenorrhea. So keep an eye out for a mixture of pan like pituitary hormone deficiency. So suppose now you are suspecting that the patient is suffering from this combined ACTH and growth hormone deficiency in a sexual suspect. So what do you do? You can measure ACTH level separately, or you can do the insulin stress test. So what happens is that with a normal pituitary function, the growth hormone and the cortisol level should rise. Otherwise, there is a deficiency of growth hormone and cortisol hormone or ACTH levels. And obviously, you can do an MRI brain also. And obviously, you can do a cortisol level and ACTH level separately. But a gold standard test is this insulin stress test. And this comes direct question, gold standard test if you are suspecting a panhypopituitarism, insulin stress test because it gives you an idea about both the growth hormone and the cortisol levels. And both of them should rise because that is a normal phenomenon. Management, the first drug that needs to be introduced is hydrocortisone. Fludrocortisone only if the patient also has adrenal insufficiency. Second drug is thyroxine replacement, which you can start after commencing hydrocortisone. That is hydrocortisone is the first drug, thyroxine is the second drug, and you can also start growth hormone therapy later on. This is again a separate question. Testosterone, the most appropriate treatment to prevent the progression of bone loss is testosterone. So even if it is an elderly patient who I do think that the patient does not need that much testosterone, but testosterone is very important to prevent osteoporosis and this sort of things. So we have to give testosterone, replace testosterone also, but not as the first line drug. Along with hydrocortisone, thyroxine, you can give testosterone. If the patient is in TAC deficiency, the first thing is rule out acidity deficiency. Because if levothyroxine you are giving in a patient acidity deficiency, that will definitely precipitate an adrenal crisis. So these are very tricky parts. So from this slide, one question is the insulin stress test. The second question is what is the finding of the insulin stress test? The third finding is which is the first line drug. The fourth question is whether you should replace testosterone or not. The fifth question is TSH deficiency. What is the next step? ACTH levels. Why? Because otherwise there will be adrenal crisis. So these are the 5 MCQs that I have discussed from this, and these have come repeatedly. Coming to the growth hormone, as we know, growth hormone is usually secreted from the hypothalamus. I mean, growth hormone is always secreted from the hypothalamus, which releases this growth hormone releasing hormone, which stimulates the anterior pituitary gland, which releases the growth hormone. So vasopressin also in the posterior pituitary, and this is from the anterior pituitary. The highest level is seen in the midnight because it secreted in a pulsatile manner. So when should you take the sample? At around 12 a.m. As always, you have to, especially for the part 1, you have to remember the messengers, cyclic MP and the calcium. And it uses the tyrosine kinase receptor based pathway, TK receptor pathway. This you just have to mark up basically. Growth hormone with cortisol and adrenaline are the counter regulatory hormones. These together are called the counter regulatory hormones. They basically increase the availability of glucose. So all these three hormones will increase the availability of glucose. That is counter the effect of insulin. This chart you have to remember. I am not going through it because it's just going through the names. Remember that in pregnancy there is a decrease of growth hormone. Also during this increased age, hypothyroidism, these type of things, it decreases growth hormone secretion. So what happens when there is growth hormone deficiency? As we all know, pituitary tumors or radiotherapy due to a pituitary tumor is the most common cause of growth hormone deficiency. In infancy, hypoglycemia is the most common manifestation. In early childhood, growth failure. In adults, osteoporosis, dyslipidemia, increased fat mass, then dry skin, all these things. And there is a definite increased cardiovascular risk. In fact, the most important cause of death in a patient who is having growth hormone deficiency is CVS, that is cardiovascular system. Most common cause of mortality in growth hormone deficiency. Again, an MCQ. So how will you diagnose? Diagnose is again by insulin tolerance test, which is the gold standard. Growth hormone response less than 9 millimoles per liter, 9 milliunits per liter is growth hormone deficiency. So if there is normal growth hormone, then if you give insulin, growth hormone will rise. If you don't, then the growth hormone levels will not rise. The response is less than 9 milliunits per liter or less than 3 nanograms per ml. What are the contraindications for ITT? That is insulin tolerance test. Again, very important MCQ. Seizures, IHD. That is CNS disease, CVS disease. These are contraindications. Also, elderly, there is a high risk of hypoglycemia. So you can do, but you have to check the capillary blood glucose before, during, and after the test. This is very important. So what are the alternatives? If you can't do, then the alternative is an arginine growth hormone receptor GHRD stimulation test or the glucagon based test. Okay. So this was about the growth hormones, and that is the growth hormone deficiency, and what are the the clinical features, and this chart, and about the insulin stress test, what are the contraindications, and what are the alternatives. Everything you have to remember. And this cardiovascular risk, this you have to remember. Osteopenia, osteoporosis also you have to remember. Treatment, obviously, if there is severe growth hormone deficiency, if this criteria is maintained, then you have to start. Impaired quality of life, treatment of other pituitary hormone deficiencies, then growth hormone. Because growth hormone is the last hormone that is to be replaced in a case of panhypopituitarism. That is also another question. So why are we so sensitive about replacing the growth hormone? This is because benign intracranial hypertension is a side effect, and it is a reversible side effect, because if you stop the growth hormone, then it resolves. Other than that, carpal tunnel syndrome, weight gain can also occur. Carpal tunnel syndrome is a common findings not only in part 1 and part 2. Once you pass these, you go to the MRCP paces. There, the common question, especially in the Middle East centers and also in the Indian centers, is an acromegaly. Acromegaly, as we know, growth hormone increases, as you all know. In there, the patient often presents with a carpal tunnel syndrome, with pain in the hands, and then you examine and find out that it is CSCTS. And then you examine, and then you have to rule out acromegaly. So these things are related, and you have to remember. Also, a contraindication is active malignancy, benign intracranial hypertension, and retinopathy and diabetes mellitus. Among them, these are the questions which comes. Okay. So read this question. Which treatment is most appropriate for patients to preserve pituitary function but deficiency in growth hormone and ACTH? As I told, growth hormone is the last hormone to be replaced. Last to be replaced. That is what they are checking here. It is enough to replace the cortisol only. Okay. Because growth hormone deficiency can be also be caused by hypoadrenalism. So you have to replace it, replace the cortisol, and after adequate replacement, recheck the growth hormone. If you see that the stress test is again positive, then think whether you need to replace or not. Yes, coming to acromegaly, as we were discussing, the cause is a growth hormone secreting pituitary tumor. Causes mutation of the GS protein alpha subunit. There is raised insulin-like growth factor 1. These I am telling, but these are all MCQs. Yes, mutation in the GTP binding protein, that is the GS section. So persistent rise of cyclic AMP, excess growth hormone. As we discussed previously, growth hormone, the mechanism is through the GTP binding protein, cyclic AMP, and the tyrosine kinase pathway. So those things, mutations in raised levels causes this acromegaly. Clinical features is actually a gold mine for questions for MCQs. Headache, visual loss because of optic chiasma compression, increased shoe size, increased ring size. These we all know: prognosticism, bitemporal hemianopia, facial appearance, sleep apnea, or features of like obstructive sleep apnea, the features. Increased sweating. Every question can appear in the MCQ, especially in part 2. They will tell that the patient has presented with a complaint of ill-fitted shoes with a problem with the hands. And the patient is telling that the patient does not want to tell photograph. This I'm telling of an actual MCQ. And the answer was acromegaly. So you have to be very well practiced to answer these questions, because they will not, part 2, they will not directly ask you which hormone excess causes acromegaly. They will not ask you that, but all they will not tell you that yes, this patient has got prognosticism with bitemporal hemianopia. What is the diagnosis? Everybody will answer acromegaly. They will give you some hints, and then you have to answer. Macroglycia causes the first 3. You have to remember these are the 3 which usually comes: hypothyroidism, acromegaly, and amyloidosis. That much is enough. Among the complications, I am just highlighting, if you can take a screenshot if you want: hypertension, impaired glucose tolerance and diabetes, increased chance of ischemic heart disease, increased chance of colonic carcinoma and polyps, cardiomyopathy, heart failure, pseudo-gout, carpal tunnel syndrome. These are the questions which have come, and it is also associated with main 1. Main 1, main 2, we shall discuss maybe next session, or it will be discussed in some other session with some other faculty. But main 1, main 2, main 2A, main 2B, these are very important. And it is main 1 is associated with acromegaly and primary hyperparathyroidism. 6% of patients are having this. Diagnostic, as I told, IGF-1 is increased, so that is the screening test, and oral glucose tolerance test is the diagnostic test. So what is the findings? Normal IGF-1 rules out acromegaly. If there is increase in IGF-1, you have to do the oral glucose tolerance test and measure the baseline GH and measure the growth hormone after 2 hours. If GH is suppressed, acromegaly ruled out. If not, you have to do a conductor pituitary MRI. So there are 3 tests which you need to juggle between and find out which test is best for that clinical scenario. Initially, IGF-1, then this oral glucose tolerance test. Ultimately, you have to do the pituitary MRI also. You have told. Yes. So in acromegaly, there is a risk of colon cancer, polyps. So regular colonoscopy screening from the age of 40 years. Management is obviously surgery. It is a first line and only management for acromegaly patients. So management-wise, yes, surgery is there, and one drug, octreotide, which can be used as an adjunct to surgery in patients with acromegaly. So initially, you have to start the octreotide because surgery will take some time. Ultimately, you have to go for, but you have to go for surgery also. In 1/3 of cases, there is rise prolactin. This has also come in an exam, so I'm just telling it here only. Yeah. So this was the first line, surgery. Among second line, we have discussed about octreotide, that is a somatostatin analog. What are the other options? Dopamine agonists like bromocriptine. Cabergoline recently has come out to be more effective than bromocriptine. And also there is GH receptor antagonist, pegvisomant. It is a third line treatment. So pegvisomant, most of you will know by the time you go into the exam, but it is only for non-responder, which is a third line treatment. The first line treatment is still surgery. Among medical management, you can go for cabergoline and somatostatin analog. It is the first in medical therapy. So overall first line treatment, surgery, first in medical therapy, somatostatin analog is octreotide. If your octreotide cannot be used, like for gallstone, if there is already gallstone disease, then you can go for cabergoline. Pegvisomant, it decreases IGF-1 levels to 90%, and you have to monitor the liver function tests. It has come in the last 2 diets actually, pegvisomant. Okay, so remember the name, remember it is third line, remember that you have to do an LFT. Which test is best way to monitor for recurrence of the transfemoral surgery? It is insulin-like growth factor 1. You have to do this test for recurrence. IGF-1 was also the initial investigation, and even after surgery, if you want to look, you should look for recurrence, then you have to measure the IGF-1. This I have already told. Left ventricular failure is the most common cause of death in this patient. It is cardiac cause. What is pituitary apoplexy? It is basically sudden hemorrhage in the pituitary gland, and MRCP favorite is in a postpartum patient. This is happening. Severe eye pain, severe headache, loss of vision, and with features of hyponatremia, hypoglycemia. What is happening? The answer is always pituitary apoplexy. Remember, it's a spot diagnosis type of case. There, at least in MRCP exam, there is no other diagnosis for this sort of cases. So sudden onset retroorbital headache, visual disturbance, vomiting, features of hypocortisolemia and Addisonian disease, that is hypotension, hyponatremia, hypoglycemia. You do an MRI, you do urgent severe replacement, and what is the indication for surgery? Obviously, if there is involvement of the cranial nerves and if there is severely reduced visual acuity. So this was about pituitary apoplexy. What are the cause? Remember pregnancy. Usually this pregnancy or a post surgery will be there in the, if the answer is pituitary apoplexy. What about pituitary adenoma? The clinical features we already discussed. This size comes in the MRCP part 1, microadenoma, macroadenoma. 10 mm is the cutoff. According to hormone secretion, prolactinoma is the most common, 35 to 40%. After that comes the acromegaly, Cushing's, and TSH adenoma, which is least common in TSH adenoma. It can also be non-secretory type. Non-functioning, non-secretory type does not necessarily realize that there is no injury or anything. There can be a high recurrence rate, there can be invasion, and increased risk of hemorrhage. The answer is corticotrophic adenoma. Most common cause is prolactinoma, we have discussed. Up to 10% in the general population, if you do MRI, there can be a pituitary adenoma. Clinical features, depending upon which hormone it is secreting, will be features. If it is non-secretory, it can be asymptomatic. It can be asymptomatic also. It can cause mass effects. The presence of secondary hypothyroidism, hypogonadism is because of stalk compression with pituitary adenoma, and there you require surgery. So for treatment wise, if it is non-secretory and incidental, then no treatment, only requires follow-up. If it is a prolactinoma, then the first line is dopamine agonist, that is cabergoline bromocriptine. Second line is surgery. So if they are mentioning that it is a prolactinoma, then surgery is not the first line. Then cabergoline bromocriptine becomes the first line. Second line becomes surgery. For everything else, first line is surgery. Second line is the medical management. And others, yes, as I told, surgery is the first line. Others are medical management is the second line, medical management. For prolactinoma, it is different. Yes, first line is dopamine agonists. That is medical management. And this have discussed optic chiasma is the part which gets compressed, resulting in less TSH action and less distinct actions. Yeah, I know I'm going with fast, but I mean, if you request, I can just send these slides because I mean, endocrinology, it's not for teaching. You just mark down which parts I am mentioning and which I'm stressing upon, because you have to read endocrinology at least 5 to 6 times. Then you will get the gist of the thyroid and these growth hormones and these things. I am not trying to teach you about the growth hormones things and these things. Okay, you have to go through it again and again. I'm just highlighting the points, and I mean, in almost every slide, I am marking the points and writing on my own also. If I go slower, then I shall miss out on a topic. Okay, because I am allotted only 2 to 3 classes. I am trying to cover a few MCQ in a last class. I can go a bit slow. Just give me what you feel. Then at last class also, I will not be doing the MCQs and actually will be doing the class like this. I have no problem. But you tell me, I think doing more MCQs will be a bit helpful because I shall be selecting the MCQs and sharing it with you. So I'm going a bit fast today, and next class also I shall be going at similar speed only. If it is a lot of problem, then I can also go slow. But the third class then will be taken up by a theoretical discussion. You tell me, I shall do like that. After a few slides, I shall again go and check because I have to go to that part and the Zoom meeting and check the chat box. Okay. Okay. So now we are entering the field of thyroid. We sorry. So we have basically completed the pituitary related things. That is TSH, we shall again discuss in the thyroid. ACTH and cortisol, we shall discuss again in the adrenals. Today we have mostly covered vasopressin related ADH and DI. And we have also discussed about hypo and hypernatremia, and we have discussed the growth hormone. Because growth hormone we will not cover anywhere else. TSH and the ACTH, those part we shall again cover there, and maybe then there we shall cover the growth hormone a bit in detail again. And we shall also cover all of these things briefly in the MCQ part, in the discussion section. Oh. So we are in the midway of today's class, and we shall be discussing about thyroid now. So starting with thyroid binding globulin. Why is it important? Because there have been MCQs in part one. I am yeah. Just can you mention in the chat box that whether most of you are from part one or part two, and then we can okay, there are only 10 of you. I thought you will be more. Anyway, so okay, yeah. So mostly for part one, they often ask what are the causes of raised thyroid binding globulin, and the first one, that is this pregnancy, OCP, chronic hepatitis, acute intermittent porphyria. These are the ones which already come. These are not that common clinically, but for this exam, it is very important, I feel, because although it has not come, I think, in the last 2 3 diets, but before that, it has come consecutively in a couple of diets. So just I wanted to share this chart. Now this thyroid binding globulin can also decrease, and their active acromegaly, large dose glucocorticoids, Cushing's, and factitious thyrotoxicosis and phenytoin. These are the ones which they have asked in the exam. Try to remember if possible. I know it's difficult to remember the causes of raised and decreased TBG. Again, these things. So we already discussed today about the growth hormone receptor and the vasopressin receptors. So make a note about in a separate notebook about these receptors and what they belong to. It belongs to a nuclear receptor. TRH receptor is usually the GQ pathway. TSH receptor is a GS pathway. These are all part 1 MCQs, guys. These are difficult to remember, I know, but yeah, you have to try to remember this thing. This is how it works. This you will not need. This is just so that if you read more and maybe you'll remember. So TRH is GQ, TSH is GS. It is associated with this inositol triphosphate pathway and increased intracellular calcium. And here it is associated with cyclic AMP pathway and T3T4. So try to remember these things. And this is very important. Okay, this is coming repeatedly. Thyrotropin is a glycoprotein hormone, glycosylated, that is also previous year's MCQ. Calcitonin we shall discuss later. I want to discuss about, we shall cover all these things today only. So coming to subclinical hypothyroidism. So subclinical hypothyroidism in a patient younger than 70, if TSH is more than 10, then you have to start treatment to levothyroxine. And if TSH is 4 to 10, then you can repeat the test in 6 months. This obviously is in a case of new diagnosis before 70 years of age. After 70, you have to start treatment. You see, high TSH, if it is a pregnant patient or non-pregnant, in pregnant you have to treat because of the baby. Otherwise, the baby will develop hypothyroidism. So in pregnant, you have to treat, clear cut. In non-pregnant, if the age is less than 65, you have to treat. If the TSH is more than 10, you have to treat. Otherwise, you can wait. This is an old chart. Now the recommendation is this 70. So please, I'm sorry, I did not see it previously. But just remember that this is now 70. Okay, not 65. This has been changed in the recent NICE guidelines only. 2023 NICE guideline, I think this is for 2019. So if you see the 2023 guidelines regarding hypothyroidism, then you will see this change. What is the significance? Why do you need to treat? Because of the cardiovascular disease. Left ventricular hypertrophy, more chance of AMI, more chance of this heart failure, left ventricular heart failure. All these things is the most common complication, and also the, as you can imagine, most common cause of death also. So this was about subclinical hypothyroidism, and as we discussed, if TSH is between 4 to 10, if symptomatic and less than 65 years, give a 6-month trial. In older people, watch and wait strategy. TSH is more than 10, start treatment even if asymptomatic. What is the monitoring frequency? Without features suggesting underlying thyroid disease, once every 2 to 3 years. But if features are suggesting underlying thyroid disease, however asymptomatic, then once a year. What is postpartum thyroiditis? Time frame is within 6 months after delivery. Course is in postpartum thyroiditis. Suppose this is a thyroid gland and thyroid hormone is stored here, and there is an inflammation. There is an inflammation. So all the thyroid hormone comes out, resulting in a hyperthyroid state. Resulting in a hyperthyroid state. And once this hyperthyroid state resolves, because all the thyroid hormones are coming out quickly, right? So after that, this is followed by a hypothyroid phase after 3 to 6 months. And after that, there is spontaneous recovery in 1/3 of cases. So there is a hyperthyroid status, there is a hypothyroid phase, and then there is spontaneous recovery. This occurs in 1/3. In the remaining 2/3, only one phase can be observed. That is, the patient may remain hyperthyroid or the patient may be diagnosed in the hypothyroid state. In the exam, usually at least 2 states will be given, followed by a history of postpartum. If the patient is having thyroid peroxide antibodies positive prior to delivery, then the risk factor is high. And also it occurs in patients with type 1 diabetes mellitus. Okay. So these are the risk factors. What is, and the treatment is usually, if it is a hyperthyroid state and the patient is grossly, clinical features are there, then you can start treatment. Otherwise, you can just wait and watch. What is subclinical hyperthyroidism? Subclinical hypothyroidism is a more clinically relevant phase which we see in our day-to-day practice. But subclinical hyperthyroidism can also occur. There will be a measurable TSH and no features of exogenous thyroid dysfunction, and this patient can be managed conservatively. So there will be a normal FT3, FT4 with a suppressed TSH level, and the symptoms will be non-specific if present. Then it will be called subclinical hyperthyroidism. The main complications are cardiovascular and bone metabolism related to osteoporosis. Increased likelihood of dementia. When does it usually occur? Usually associated on the setting of thyroid overactivity due to Graves' disease or autonomously functioning thyroid nodules. That is the usual cases where you usually diagnose active hyperthyroidism. There also the patient may be having a subclinical hyperthyroidism, where TSH level will be suppressed, T3, T4 will be normal, but patients will not have too much of clinical features. So we have discussed about postpartum thyroiditis. Now the time is come for discuss about decurvance thyroiditis. The clinical feature which will always be given if they want this to be the answer is this: tender goiter, raised ESR, globally reduced uptake on technetium scan. Diagnosis is decurvance. Thyroid inflammation, usually after viral infection. And just like in postpartum state, increased release of the thyroid hormone occurs. So there is a T3, T4 rise, but overproduction does not occur. There is no overproduction. It is just an increased release. So I told you to make a list of the autosomal dominant, autosomal recessive, X-linked recessive diseases. Second, I told you to make up a list of drug interactions. Third is this HLA related things. The fourth is your syndromic diseases, which commonly comes in the exam. If you make these 4, then 1 to 2 questions come, then 7 to 8 tough MCQs you can solve. And often these 7 to 8 marks is the difference between passing your part 1, part 2 or failing your part 1, part 2. So make your own MCQs, make your own lists, because you will know which parts you are deficient upon and focus on those in your last 1 month. But don't make the list and keep everything for last 1 month. Go through them intermittently. When you are tired, when you don't want to study anything new, don't want to do MCQs, go through this list. These are very important points, and believe me, these are much more important than telling you about decurvant thyroiditis. Every one of you will study decurvant thyroiditis and go to the exam. You will know that with tender goiter, the answer is always decurvant thyroiditis. But these are the ones which are very important to be taught to you. At least I feel that. Anyway, so what is the management? Management is, it is a self-limiting condition. Symptomatic control, if there are features of hyperthyroidism, then you can start the management. If not, then you can just wait and watch. In very severe disease, only you can give prednisolone. If hypothyroidism develops, then you can give. Because why hypothyroidism is occurring? Because these membranes have been destroyed, and all the thyroid hormones have come up and have been used up. So the patient will soon go into a severe hypothyroid state, basically hypothyroid crisis. And that is why in these cases steroids are recommended. Otherwise, steroids not needed. Only if they are telling that yes, now the patient is going into from a hypothyroid, what will you do? Use the steroids. Again, they have just highlighted the issue about the treatment. Subclinical hyperthyroidism, this is a repeat, I'm sorry, I just repeated the slides. Coming to thyrotoxicosis, the most important part, and the Graves' disease. So thyrotoxicosis, what are the causes? More than 50% of cases here will be Graves'. Other than that, it can be a toxic nodular goiter, it can be solitary toxic adenoma or Plummer's disease, or it can be thyroiditis, decurvence or postpartum, as we have discussed already. It can be acute phase of Hashimoto thyroiditis, thyroid Hashimoto, we shall discuss at the end, or it can be a part of the amidron-induced thyroiditis. Secondary thyroiditis can be because of a pituitary adenoma. It can become an ectopic cause. But for exam purpose, these and amiodarone, these are very important. The two phenomena, Jod-Wasdo and Ulf-Chaikov, these come in the exam. If the patient has been on a iodine for a long period of time or receives iodine-induced contrast, then the patient may go into Jod-Wasdo phenomenon. It occurs due to overactivation of the entire thyroid gland or because of activation of some autonomous nodules. Basically, a hyperthyroidism. Wolff-Chaikoff effect is hypothyroidism following iodine excess. So opposite effects. So Jod-Wasdo is hyper. I always remember as a wolf or a W. It occurs later in the alphabet, right? So that is hypo. Jod-Wasdo is the hyper. B is there. So that is the comes first, hyper. What is thyroxine abuse or thyrotoxicosis facitia? Combination of low thyroglobulin, decreased uptake on scintigraphy, raised T4, low TGO, raised T4, and decreased scintigraphy uptake. That is decreased uptake. That is a feature of thyroxine abuse or a factitious disease. Thyrotoxicosis factitious. Features of thyrotoxic, please mute yourself. Features of thyrotoxicosis are like mostly heat intolerance, excessive sweating, weakness, fatigue, intestinal hypermotility resulting in diarrhea, pretibial myxedema, obviously goiter, non-tender. If tender, then it is decurvence. Non-tender, smooth, it is goiter. Eye signs, obviously, lead lag, lead retraction, you need to know. Lead retraction is non-specific. It can occur in any thyrotoxic state, including thyrotoxin potentiating the activation of catecholamines. What is the difference between thyrotoxicosis and Graves' ophthalmopathy? Graves' ophthalmopathy, there will be exophthalmos and edema of the periorbital tissue. So these signs are more specific for Graves, exophthalmos and edema. Lead lag, lead retraction are mostly the features of hyperthyroidism or thyrotoxicosis. Cardiovascular wise, as we know, palpitation, tachycardia are telltale features of hyperthyroidism. Atrial fibrillation is very common. Also, systolic pressure will be increased, diastolic pressure will be decreased because of decreased peripheral vascular resistance. Endocrinologic wise, infertility, dysfunctional bleeding, erectile dysfunction, fine tremors, as we know, and myopathy, osteopathy, and osteoporosis due to direct effect of T3. This is a separate MCQ. What is the reason for osteoporosis in a case of hyperthyroidism or prolonged patient who is being prolonged therapy for long? This is because of the T3 effect on osteoclastic bone resorption. Besides that, the patient may have insomnia and these things. So hyperthyroidism is truly a systemic disease. These are the general causes. These are the eye-related causes: cardiovascular, endocrinological, musculoskeletal, fine tremors, osteoporosis, osteopathy, quadriceps myopathy, and restlessness and insomnia. Investigations, we know T3, T4, TSH. Apart from that, Doppler of the ultrasound. Doppler ultrasound of Doppler ultrasound of thyroid gland, thyroid scintigraphy. We have to see the uptake by the radioactive iodine uptake test, RIU test. It can be a hot nodule, hyperfunctioning tissue uptake. It can be a cold nodule, non-functioning nodules. You can do a PET scan, or not a PET scan. This RIU test scan can also pick up ectopic tissues. Main contraindication is pregnancy and breastfeeding. So these are contraindications. So this radioactive iodine uptake is very important for MCQs. So one is the blood tests, one is the USG, third is the radioactive iodine uptake. General laboratory features usually do not come except the Graves' disease features, which includes leukopenia or relative lymphocytosis in the case of Graves' disease. Osteoporosis, osteophytes, we have already discussed. Yes. Most sensitive blood test for excess thyroid is free T3 level. It is not TSH or free T4, it is free T3 level. So free T3 level is a cause for osteoporosis, also the most sensitive findings here. Management is basically management of hyperadrenal symptoms by propranolol, and also you have to use antithyroid drugs, mostly methimazole, and also propylthiouracil. Propylthiouracil is a contraindication for in a case of pregnancy. Also, liver disease is a contraindication because it raises the liver enzymes. Both propylthiouracil and methimazole can do that. Propylthiouracil is a contraindication in pregnancy. Methimazole is drug of choice in first trimester of pregnancy. You can also use radioactive iodine ablation. So radioactive iodine is used both for diagnosis as well as for management. And lastly, surgery. Obstructive symptoms, malignancy suspicion, Graves, all of ophthalmopathy, all are indication of surgery. In acute thyrotoxicosis, basically you need to stop the aspirin as it can worsen the storm. And we have already discussed thyrotoxicosis as well reversible cardiomyopathy. So ventricular failure, atrial fibrillation, mediator failure, these things can happen. In pregnancy, early pregnancy, propylthiouracil is a drug of choice. There is a very small risk of fetal abnormality with carbimazole. In late pregnancy, however, carbimazole can be used. And what is the side effect in the neonate with carbimazole? Aplasia cutis of the neonate. Postpartum patients, again, carbimazole is recommended. It is safe. Main contraindications is block and repeat regimen should not be used in pregnancy. Also, radioactive iodine is contraindicated. So this is a drug of choice in early pregnancy. Late pregnancy, as usual, you can continue with methimazole and carbimazole. You have to monitor basically maternal free thyroxine levels. In women who have been treated with antithyroid drugs in pregnancy, FT4 and TSC levels should be monitored every 4 weeks. So monthly. Again, I have highlighted small risk of fetal abnormality, carbimazole recommended to propylthiouracil in first trimester, carbimazole in trimester second and third. Propylthiouracil can cause hepatotoxicity, P2 mediated hepatotoxicity. In thyroid storm, basically you have to shift a patient to ICU. Rest are same, propranolol. If there is a hyperpyrexia, paracetamol. If there is agitation, sedate the patient. You can use chlorpromazine or anything else. And then inhibition of thyroid hormone synthesis is first and now is propylthiouracil. You can also use potassium iodide, which will, through the Wolff-Chaikoff effect, it will decrease the inhibition the thyroid hormone release. So what is the mechanism of propylthiouracil methimazole? It inhibits the thyroid hormone synthesis. What is the mechanism of the potassium iodide? It inhibits the thyroid hormone release. And the mechanism is Wolff-Chaikoff effect. It needs to be given at least 1 hour after the antithyroid drugs. Third is inhibition the peripheral conversion of T4 to T3, which is mostly by the steroid.
जेवण झालेलं आहे.
Cholestyramine basically mechanism is inhibition of the enterohepatic circulation. So in storm, the drug of choice is propylthiouracil. Pregnancy first trimester, it is propylthiouracil. In storm, it is propylthiouracil. Otherwise, you can use carbamazole also. Very important, amiodarone-induced thyrotoxicosis in type 1. Basically, type 1 is basically amiodarone contains increased iodine, which increases thyroid hormone synthesis via a Jod-Bazdo effect. So hyperthyroidism because of the increased thyroid hormone synthesis, because of lots of iodine. So goiter can be there. Color Doppler blood flow is raised. IL-6 levels will usually be normal. Management is with antithyroid drugs. In type 2 is basically destructive thyroiditis. So it is more likely more similar to the conditions like postpartum or decurvence, where there is increased release of the T4 and T3. So goiter will not be there. Blood flow will be reduced. IL-6 will be markedly elevated, and the uptake can be minimal to none. And here steroids is the drug of choice. So you will be given a clinical scenario where you have to differentiate whether it is a type 1 or a type 2. For the all exam purpose, color flow Doppler is the most likely test to differentiate between the type 1 and type 2. Okay. So color Doppler, because here the thyroid gland is destroyed, so it will decrease blood flow in type 2. In type 1, they will be increased because of more iodine and more thyroid hormone synthesis. Initial management of amiodarone thyrotoxicosis is that in type 1, it is high doses of antithyroid drugs. In type 2, steroids. But in all practical purpose, if amiodarone induced, then we use both steroids and thiamidines, and we investigate. If there is a rapid response, then thiamidines can be tapered off because it is possibly type 2. Type 1 usually have a poor response to treatment because it takes some time. Steroids act very fast, decreases the inflammation, decreases the thyroiditis, the patient is half cured. Which eye signs are specific? We have already discussed. Proptosis, periorbital edema, chemosis. These are more typical. Lid lag, lid retraction are more signs of increased catecholamines and can occur in other conditions as well. Coming to thyroid cancer. Thyroid cancer, there are 3-4 questions. The first question is medullary carcinoma associated with MEN2 RET gene mutations. Papillary carcinoma can also be associated, but for all exam purpose, MRCP purpose, medullary carcinoma, MCT is MEN2 and RET gene. If the patient gives a history of ionizing radiation exposure, more chance of papillary carcinoma. So for papillary carcinoma is most frequent. Presence of cold nodules or incidental finding. Best prognosis of them all. For follicular, it is more rare, again more common in females. Spread is hematogenous, so often there can be METs. Overall prognosis is still good. Medullary cell, we have already discussed that it is MEN2 and the RET gene related. It is cancer of the parafollicular cells or C cells. Prognosis is poor. Mets can be there. If it is a Hashimoto's associated with a cancer, then it is more chance of being a lymphoma, non-Hodgkin's, locally invasive. As we know, it is a malignancy. It is a, as always with a malignancy, it is poor prognosis. So it is only in the papillary carcinoma, thyroid carcinoma, the prognosis is excellent. If it is follicular, it is still good. Otherwise, it is a poor prognosis. And of course, anaplastic is very aggressive, non-responsive treatment, and it is fatal in a few months. So papillary P, most prevalent P, palpable lymph nodes P, best prognosis P. So all P. Best screening test for medullary thyroid carcinoma is calcitonin level, and the test name is a pentagastrin stimulation test. Okay. 2 to 5 minutes after pentagastrin infusion. Rise in calcitonin is suggestive of medullary thyroid carcinoma. So suppose you have a thyroid nodule and you want to do an FNAC. Microcalcifications, low echogenicity, microcalcifications, best features for malignancy. If it is there is increased internodular vascularity, more chance of benign adenoma. But if there is increased marginal blood flow, if it is increased internodular blood flow, then it is more chance of thyroid. And these are coming up in the exam more and more. Increased marginal blood flow, benign. Increased internodular blood flow, cancer. Remember the referral purpose. If it is same-day referral, if the patient is strided, then it is a emergency-based referral. Otherwise, you can give it gradually. That much remembering is enough, I think. So these are the last slides. Others are for the next class. These are empty slides still, so I shall fill it up by the next class. And we have left a bit previously, so we shall be going back to that and we shall be discussing that. This latter part of the thyroid is the more important part for the exam. This subclinical hypo and hyper and this malignancy and the prevalences and the medullary thyroid, especially thyrotoxicosis, Graves, these type of things. Yeah. So here the most important part is Hashimoto's thyroiditis. If the patient is having a goiter with a hypothyroid with anti-TPO, and suppose the patient is having some sort of lymphomas, then the diagnosis is the Hashimoto thyroiditis lymphomas. Features are due to decreased features are usual features of hypothyroidism. Fatigue, cold intolerance, hypothyroid myopathy, weight gain, decreased sympathetic activity, decreased sweating, constipation, bradycardia, generalized myxedema, puffy appearance, myxedematous heart disease, dyspnea, hyperprolactinemia, abnormal mens. If in a rarely it can occur in a male patient also, they are erectile dysfunctions. So the usual features of hypothyroidism you have to remember. There is nothing extra. Cold clammy skin, decreased sweating, patient will be like a more obese patient, usually female patients, cold intolerant, carpal tunnel syndrome, this set of things. Laboratory wise, there will be euvolemic hyponatremia, glucose intolerance, dyslipidemia, hyperprolactinemia. This is the one which comes in the exam. Hyperprolactinemia. Anti-TPO antibodies is more classical to be associated. So if you have made a diagnosis of Hashimoto, suppose female patient with features of hypothyroidism and there is a lymphoma, there is a this anti-TPO antibodies positive, and prolactin levels are high, and you know that it is the Hashimoto's, in the next step is to rule out additions by a short synaptin test. Because otherwise treating the hypothyroid will mask the additions and precipitate adrenal crisis. What is the complications? These patients basically can go into a myxedema coma. The treatment is with intravenous thyroid and supported treatment with hydrocortisone, because hydrocortisone in a myxedema coma is life saving. Besides, myxedema coma is often associated with a hyponatremia, hypothermia, hypoglycemia. So you have to treat these also. If there is an associated primary thyroid lymphoma and is a non-Hodgkin factor, then you have to give the appropriate management, that is chemo or radiotherapy basically. If the patient goes into Hashimoto's encephalopathy, it is extremely rare. It is considered to be an autoimmune encephalitis. You have to do a CSF and send an autoimmune panel, which is fast becoming a standard of care, at least in an ICU setting. Features are that of encephalitis, altered mental status, myoclonal ataxia, anti-TPO antibodies obviously you need to do if not already done. It is steroid responsive, so you have to start a steroid and supportive management with IVIG or plasmapheresis. This I think this is same for any cyst. If there is a sudden rise in cyst which is becomes acutely painful, then it is a hemorrhage. Pendred syndrome is an exam favorite. Just remember, it is signs of deafness and hypothyroidism. It is a sensory neural deafness. It comes up in the exam. I don't know why, but maybe it is very common in the West or something. So it comes up in the exam. So I have included it here. There is a characteristic 1.5 turn turns in the cochlea. Usually it is a 2.5 turns. If you do audiometry or you do a MRI of the imaging, not audiometry obviously, audiometry will give the sensory neural deafness. If you do an MRI, then it will show this 1.5 turn. It is a chromosome 7. Somewhere I wrote gave a list now which 4 things you need to take. Yeah. So add 5. The 5th is a chromosome list. So again, you have 9 to 10 MCQs which you can answer. And do it in MCQs mode. So make a list of your own. Okay, guys, don't neglect this thing. Riddle's thyroiditis. Okay, we have not discussed, but Riddle's thyroiditis is one where there is a diffuse fibrous growth. So if it tells that the patient is having over a few months, the patient is having the neck swelling, which is now becoming very hard, then painless, hard, solid thyroid enlargement, stony, woody. These are typical MCQ clues, Pregnancy, it is postpartum thyroiditis. Postpartum thyroiditis. If it is like painful, then it is de Quervain's thyroiditis. De Quervain's thyroiditis. If it is woody hard, then it is Riddle's thyroiditis. So these are the clues to the MCQ for fast diagnosis, because it is a time sensitive. There are lots of questions, and there are parts where you actually have to read the question 2-3 times. Don't if you get this question, then answer it fast. Don't overthink. There can be associated hypothyroidism, but because it is a chronic condition, so many patients are euthyroid and do not need a treatment. There can be a fibrotic invasion adjacent structure, that is the hypoparathyroidism can occur also. Do a biopsy. If it is symptomatic, use steroids for treatment and rule out malignancy also. So this was the class for today. I know I went a bit fast, but you can, if you have any doubts, you can message me, or you can tell that which part if you want to redo a few parts. Okay, so somebody giving part 1, that's all right. This class was specifically part 1 and part 2 both. Definitely you'll get a few
Sir, I am part 2. Sir, I am part 2.
Yeah. I know most of you are part 2.
Yes,
so
yes.
it was mostly for part 2, and I have tried to tell the few specific questions. Those questions only comes in part 1. Those memory-based questions. So I think this will help you both. And so next class I shall do the adrenal and the calcium metabolism and a few subtopics. Again, around the 1.5 hours class. So try to be on time, because otherwise, class was 7, now it's 8:40. So 1 hour 40 minutes I took. So if you come on time, you can cover a bit more topics, because endocrine is a huge topic. It's you will get a few questions. You will get 12 to 15 questions in your exam from endocrinology. So you'll get a few questions in endocrinology. Okay, so see you in the next class. Thank you for listening. I hope this class will be helpful.